Good morning and welcome. This is my first panel of this festival, and I hope you folks have been having a wonderful time so far. And I am just so thrilled to be here with these two experts to be talking about matters of the heart. So Martha Gulati is the Associate Director of the Barbara Streisand Women's Heart Center at Cedars-Sinai Medical School. There you go. In Los Angeles, and the principal investigator of the Women Take Heart study, which we'll be talking about. And Dr. Herman Taylor is the director of the Cardiovascular Research Institute at the Morehouse School of Medicine in Atlanta, and the inaugural director of the Jackson Heart Study. So both, which we will also be talking about. So we have a lot to get to. Matters of the Heart covers a lot. So we will start right in at the beginning. Let's start with prevention. What new prevention technologies are currently in use right now? Any of us could get it if we wanted to. That excites you. Martha, we'll start with you.
Well, I think the exciting things in prevention, if you want to talk tech, I mean, there's simple things, but the simple things work. And just being able to check blood pressure every day for our patients work, and they're getting better, and they're smarter, and they're able to download them, and they're able to allow us to work and interface with our patients. And, if we can cure hypertension, we can reduce heart disease in this country significantly.
We've been able to check blood pressure at home for some time now, but what you're saying now is it gets integrated so that you can see what's going on.
Exactly. They're smarter, easier, and they're easier for us to know what's going on. So I think technology is changing, though, prevention in so many ways. I mean, everyone's bringing their smart data. Whether it's accurate or not is another thing, So even though I know some of you probably wear Oura rings and think that it's giving you blood pressure, that accuracy hasn't been yet really fully established. That's actually the surprising thing. With all the development of new technology, those big bulky blood pressure cuffs, even if they're a little bit smarter, are still more accurate than any of the little sexy devices.
Is everyone hiding their Oura rings right now? Herman,
blood pressure is so important and has been for so long, but still today, possibly the leading contributor to heart disease worldwide. We're still struggling with that basic parameter. If we could just get that under better control. We're doing an interesting study about to launch, looking at actually former NFL players. Everybody thinks former NFL players, they think about concussions, they think about CTE and so forth. But what kills most former players is cardiovascular disease. And their heart, as a general rule, their blood pressure tends to be out of control when we see it. So we're working with this remote blood pressure control device that automatically uploads the blood pressures via Bluetooth technology to a central monitoring station where we used to call them physician extenders, but people who are not necessarily MDs, but well versed in a protocol, they can respond to out of control blood pressure and get people back under control. Yeah. Or if they're not under control to begin with, very rapidly get them to a state of control. So blood pressure sits at the center of a lot of cardiovascular disease.
Well, now you've intrigued me about football players. Is cardiovascular disease the most likely killer, because that's the truth for any community of men, or is there something special about football players?
Well, that's a big question that we're looking into. So you're right. It is true universally that cardiovascular kills more people than anything else. But there seem to be some interesting particulars about the football life. And we've published on, and others have as well, on the connection between concussions and subsequent elevations in blood pressure. Certainly in a concussion that happens acutely, say a car accident, blood pressure goes up in the wake of that. But we find that serial concussions or even subconcussive brain trauma can contribute to elevations in blood pressure long term. Oh. So that's one potentially contributing thing. Also, to control the chronic pain that so many athletes face, a lot of them take a lot of non-steroidal anti-inflammatory drugs, often by the handful, just to get through the day. And that, of course, is a contributor to multiple types of cardiovascular disease. So, they can contribute to heart attacks. They can contribute to elevated blood pressure. So they're a special group that we're taking a deep dive into looking at.
Oh, that's interesting. So we were just talking about prevention technologies that anyone could use right now. How about on the horizon? Do you hear about things, new technologies for prevention that make you say, wow, I can't wait to get my hands on that and use that for my patients?
Well, I think everyone is excited about the new technologies because everybody's either has an app on their phone that does something, or wears one of those devices. I have a smart watch. I'm sure people have the Oura Ring. Every day something's being developed. The thing that I always will rein people back from, because they do bring this information to our clinics all the time, and they're like, well, this says I'm an AFib, and we're like, you're not an AFib. Because, validating these devices has become a big challenge actually for the FDA. You can't, they're not going to invest a lot of these companies in studies. And so that really is the hard part. Whereas with Apple, for example, that is one company that said, okay, let's validate what we're saying we can do. And we did studies in our cardiology community to show how can it be helpful, how will it be wrong? And we know that, and we're able to work with it. But that's a great thing. I mean, there's a lot of development going on right now, and all of these apps are actually, many of them are related to prevention. The accuracy of which I still think that there's a little hesitation from our side to know, are they accurate? And so people bring us all this data, and it's great, and usually it just leads to more testing. I don't know, Herman, if you'd agree with me, because we don't know the accuracy of the data. But I do think it's exciting. I mean, there is things that are happening that are going to change the way that we can do prevention and deliver, maybe identify disease earlier in people. And that's ultimately what we want to do in prevention. We want to know who's at risk and who isn't, who can eat steak without any consequences and who can't. And if we can tease that out, one day we will personalize prevention the way, with maybe a pinprick of blood, be able to say, you're at higher risk, you're not at high risk. And, maybe the treatments and the strategies will be different.
In so many ways, we're on the cusp of this golden age, if you will, for cardiology and prevention and therapeutics. The challenge, of course, is that golden age is not glittering for everyone, right? I forget the quote. It says that, how does it go? That the future is here. It's just unevenly distributed, right? And I think one of the challenges that I at least want to put on the table, and we'll talk more as we go, is that maldistribution of opportunity to take full advantage of these things. The information, the important databases that go into the development of drugs, development of AI, development of algorithms. We really do have to tread into that area of inclusion and diversity of the people that contribute data that informs therapeutics and prevention strategies. And like I said, I think we're going to touch on that as we go.
Yeah. If I could give you one example, though, of a therapy that may be coming, just that's exciting, at least in the cardiology world. There's a company called Verve Therapeutics, and they have developed a way for when people have a genetic disorder and they make too much cholesterol, that they can go in and change that base pair in the gene where the abnormality is. And they've done it in primates, and they've shown that they've corrected it, and the cholesterol's gone down. Now the human trials are ongoing right now. This is something we talked about, but never really knew when could it come to fruition. Like I always would joke with my patients saying, well, one day we'll be able to correct your gene for that, but right now you have to take this laundry list of medication. If we can do this, one and done therapy, that's going to change a lot, because we're going to learn from that about other genetic disorders and be able to deliver those therapies. Why they haven't just jumped out and been available for everybody, and why we need the trials, is we got to make sure not only do they do what they do, but they don't have consequences of editing other DNA and then having adverse consequences. And so that's why they're being watched very closely. to see what will happen with the patients who are brave enough to be in these trials.
And do you have concerns also, like Herman, about how this will be available sort of across the board or not across the board?
Oh, absolutely. I think with everything that we do, we need, newer therapies and devices, anything that we use are expensive. Who gets them? It's always divided by socioeconomic status. You can even think of the GLP-1 receptor agonist medications that everyone's so excited about, can cure obesity, and yet the patients that need it the most are the ones that are most likely not to get it right here and now. And so we need to really be thinking about equity in everything that we do and any device that we develop. I mean, even when they develop devices and they haven't tried it out on skin like mine or skin like yours, do they work? We use these pulse oximeters in the hospital every day. And, we find that they aren't that accurate in people with darker skin. We don't ask those questions. We don't know how are we treating people? So we need to, that's just a simple example, more advanced therapies, we need to be thinking, do they work in everyone?
I'm glad you brought up the pulse oximeters. Those were developed so long ago that I feel pretty confident that color of skin probably was not taken into consideration when those studies were done. Do you feel like things have changed, or is color of skin, other gender, is that being taken into consideration when new prevention and treatment technologies are being developed?
I'd like to say it's getting better, but I know it's not fully there. I would say, so a lot of the work I do is related to women, and I still call out trials on social media and other ways saying, where are the women? Where are the women? Why did you do a trial that has 0 women? Unless it's something in an organ that only a man has, I don't see why women aren't included. Similarly, people from diverse backgrounds, where are they? We're a diverse country. How do we not know if things work in everyone? And I'm not saying that, I know race is a social construct, but even simple things like the color of our skin, knowing do these things work? Yes, the pulse oximeter has been around for a while, and it took a pandemic where people had these at home going, what's happening with me? And for people to be called out on this. Medicine has the same issues that we have in society. They're just accentuated, in my opinion. And so when there's things that we don't consider, it's also not always considered in medicine. And research particularly, it's somehow apparently easier to get white men into trials than any other group. I don't know if the white men just like to be in trials, but we need to be targeting everybody and making more efforts. And that, for me, has been the struggle, especially in women's cardiovascular health, and why we're really at the infancy of understanding women's hearts, is because we really didn't put them in the trials, and we're still, to this day, still playing catch-up.
Yeah. Well, I will say, Martha, that we could have a whole day talking about why African Americans and others are less likely to be involved in those trials, beginning with trust, right?
Yeah.
And also extending to the efforts made to go where the patients are. And also, this is also trust, why should a group of people, just in general, trust the research when it's controversial as to whether they might get care through instruments like Medicaid, right? How can we morally say, we're going to legislate you out of access, right? Or we're not going to expand to include you in access, and then turn around and say, well, we need to include you more in research.
Yep.
I mean, that's a real moral dilemma, at the least, and it's an extractive proposition at the extreme. So I think there are reasons that, people like you and I really have to work hard, and also we have to talk to the people we're interested in helping, right? We have to hear from them as to why there are barriers, or what are the perceived challenges for being involved.
Martha mentioned a treatment sort of on the horizon that she's excited about.
Yeah.
Any treatment prevention on the horizon that you're just waiting to get your hands on?
There's so many possibilities. I'm really really a big fan, of course, of artificial intelligence and what that can bring about. And I think our ability increasingly to better predict major events, for instance. Right now we can say you're at a 10-year risk for having this event of about 7.5%. Well, that's great, and it does help us decide what therapies you need of those therapies that we have available today. But it doesn't narrow it down very much for you. You don't know if you're in risk or at risk in the next 6 months or the next 6 years. You don't know whether activities that you're interested in, diets that you might try, exercise regimen you might try, whether you face a greater acute risk or long-term risk. That type of thing, I think AI can help us get closer to resolving. AI also will help us be better doctors in general, which is a whole conversation, but I'm excited about that, again, brave new world that artificial intelligence is presenting to us.
So you're saying that AI might help doctors better predict an individual's risk, and
For sudden death, for a cardiac event.
We're using them right now, actually. We're using them when we do imaging of the coronary arteries. We use AI now every day to tell us about the plaque that we're seeing in the arteries and detecting higher risk plaque versus lower risk plaque, knowing that they're at higher risk if we see certain features. And that's being applied right now. If you go for a CT angiogram, they are using it and telling us that this person's at a higher risk for a subsequent heart attack or higher risk for developing heart disease. So we're using it already. I think one version of AI that I hope gets used more is there's a study in women specifically where they listened into the conversation when women were describing cardiac symptoms. And it was cardiolinguistic technology. It basically just listened in and recorded the words. And what it found in at least this study was that, women did say the words chest pain or chest pressure. 90% of them did. And so this idea that women don't experience the same symptoms may not be entirely true. It may be that we don't hear women the same way as we hear men. And I love that if we can incorporate that in the emergency room just to make sure that that wasn't missed, that could change the discharges and the heart attacks that happen at home, which we know happen disproportionately more for women. This is a way to make us better doctors. I'm not scared of AI. I'm excited if it makes me better at caring for people.
Right, exactly.
You've landed on a really important point, because I know that we've been talking about women having different symptoms of heart attack for many years now. I mean, I've written stories on it. Many of my colleagues have. It's really out there. And you're saying maybe that's not quite true?
Well, we put it in the chest pain guidelines, which I had the honor of chairing. And we actually said that we used that study that I just talked about and 2 other large studies that really have shown that at least in our contemporary people having heart attacks, women, actually 90% of them have chest pain or chest pressure. Now, it is true, women are different than men, and women tend to have more accompanying symptoms. Chest pain or chest pressure may not be the most important symptom they experience, so they only mention it once. But women are good at describing things, and men kind of just say one word, I guess. That's what we found in these studies. So we emphasized in the chest pain guidelines through the American Heart Association, the American College of Cardiology, to really, listen to women, think about heart disease as a risk factor. Since it's the leading killer of women, we should be thinking about heart disease when they come into the emergency room and assess them for it, understanding that there's subtle differences, but there are many similarities.
So it may not be that women don't experience things differently. It may be that they express it differently and that they're heard differently.
Exactly.
Okay. And are there sort of similar parallels in the Black community?
Yeah, there are. Some of I guess perhaps the first study I did as a cardiology fellow back in, I won't say when, looked at the notion of healthcare seeking behaviors among African Americans confronted with chest pain. Right? And what we noticed was that there was a higher frequency of misattribution of the symptoms to something other than heart. And understand the context. The context was at that time, there were a series of beliefs about heart disease that were prevalent. Heart disease happened to high-powered, decision-making white males.
Yes.
Those were the people who had heart attacks.
The Hollywood heart attack.
The
I heard
Hollywood
you,
heart
right,
attack.
right.
This
Do
is
you
the
remember
this is the 90s,
Netter
folks.
diagram of the white man, the Netter diagram of the white man having a heart attack?
Exactly.
It was in our medical textbooks.
It was in the medical textbooks and embedded in our heads. And a friend put in the New England Journal a list of the myths that existed, that heart disease in African Americans was infrequent. That, again, it happened only in a certain group of people who were very privileged and who had the pressures of the world resting on their shoulders.
And black people don't have the pressures of the world. That just inherently doesn't make sense. But go ahead. Sorry.
Right. So we found some of these misattributions, and again, that's the way people thought, and it had infiltrated the way people saw themselves. That wasn't my problem. I don't necessarily feel threatened by that as much as the banker down the street. Well, of course, statistics and epidemiology over time has revealed the true picture that African Americans are perhaps at more risk. So, yeah, these kinds of issues emerge across ethnic and racial lines as well. And the predominant symptom report will be chest pain, chest pressure for African Americans as well as other groups. The other side of it, of course, is that the physician who's taking care needs to have an index of suspicion to match the risk. I think in recent years, we have really sort of centered heightened vulnerability among the African American population. And I think it's had a very important role in sensitizing caretakers to the possibility of heart disease, heart attacks in black women and black men. So that's good. There are other consequences that I hope we'll talk about as we go along. But it is important that we recognize that the leading killer of black men, black women, white women remains cardiac disease, coronary disease in particular.
Let's talk about AI for a minute. You were saying you're excited and you're not scared of it. Or do you have any concerns about the data that feeds it? Because AI is only as good as the data that feeds it.
Well, absolutely. And that's the questions we need to be asking when people are introducing AI and saying that this works, but who did you study? Ultimately it matters. Are you inclusive? Are you using a diverse population? Do you analyze? Does it work in everybody similarly? Is it as accurate in everyone similarly? So we have to be asking those questions and putting rigor behind AI research. I mean, that is required. You can't just, it's sexy right now in cardiology to say I do AI research, but you want to make sure they're doing the right thing and they're doing it before things become broadly applied, that it does work. I mean, in everyone, or at least give the stipulations of who you left out. I have a colleague at Stanford, she and my other colleagues there are looking at CT scans and looking at calcifications that they can see in any CT that they might have just had done. Maybe there's somebody who was worried about their lungs, and so then they're taking, if they see calcium in those coronary arteries, they're saying, okay, like if we can see that, you're at higher risk for heart disease, sort of like doing a coronary calcium test, and then giving alerts to their physicians and seeing what happens. So far, the preliminary data is looking exciting, that people are being more proactive and preventative. But what we haven't seen yet is by race. Are certain people not getting that information? Are their doctors not addressing it? Or the patients get the information too, but what if the physician kind of goes, oh, you don't need to worry about that? If there's deference to the physician, okay, the physician knows best. We may be missing people in that way too. So we really need to make sure we're including everyone when we're doing research is the ultimate thing.
Right, and it's not only helping the people who are left out, it makes AI better.
Yes.
Right? If we have a diverse, heterogeneous source of data, the data is better, right? And so that helps every white man, every white woman, all of us do better. We're in the habit, I think, of looking at the white male as the reference, right? That if we can just reduce the difference between us and the white male, then everybody's better. But I think really that's the wrong horizon. I think there's something beyond what we currently use as a reference. How best to say it? It's important for us to remember that if we look at the health of the American white male, that actually is not so great on the world stage, right? We need to reach beyond that, and how I think that's one of the reasons I'm excited about AI. I think it can show us those new horizons. I think we can take data from a diverse group of people and actually begin to formulate approaches that can take us to a new level. So when I say I'm excited about the future of AI, I really am. And there's so many other things we can talk about. But let's aim for a new, higher horizon for everyone. But we don't want to leave anyone behind.
Absolutely. Let's talk about your studies. Why don't you start, Herman, the Jackson Heart Study. Tell us what it is. And
Okay. Well, now, for 15 wonderful years, I took part in the establishment and leadership of the Jackson Heart Study. I was the original principal investigator. That study now is still going on, much like Framingham. Is the audience familiar with Framingham in general? Much like Framingham.
Explain Framingham a little bit.
Okay, all right. Let's go back to 1948, folks. In 1948, an important set of things happened. One, the federal government formed something called the National Heart Institute inside of the National Institutes of Health, in the wake of a few years ago losing a beloved president in office because of a cardiovascular event, a stroke, but still in the cardiovascular family. And the end of the war also pointed to epidemiology facts for us. That is, now the war wasn't killing so many Americans. What was killing Americans? It used to be pneumonias of various types, tuberculosis and so forth. Now it was clearly heart disease. So we started something called the Framingham Heart Study, where we walked into a typical American town and basically said, we know this. If you follow people forward in time, some will have heart disease, some won't. We want to find out what distinguishes the two groups. And so they got 5,206 individuals enrolled in the first Framingham Heart Study, and that study is still going. There have been generations now. and they gave us, to be brief, they gave us things like risk factors, right? That's a common phrase now, but they coined that phrase. And the list, as you know, blood pressure, cholesterol, diabetes, et cetera, is on that list. So tremendous contributions. Well, fast forward from 1948 and all the decades between then and 2000, we in America see, as we look around, that yes, incredible advances have been made in cardiovascular disease. However, not everyone is benefiting. In fact, there's a huge gap, a disparity between African Americans and the rest of the country. And we have woefully little data in important areas. Why don't we attempt something like the Framingham study in an all-black community or with all-black enrollees? And that's what the Jackson Heart Study is. It would take a lot of time to go through some of the important, I think, insights and advances. But I'll say this as one succinct point, that the importance of the social determinants of health has been deeply underscored, quantified, and brought into an area of scientific rigor by this group of African Americans, numbering 5,306. We kept recruiting until it was larger than the original Framingham study, it was 5,200.
Oh, that's great. That's great. That's great.
So they have shown us many important insights and set the stage by completing being a part of the largest repository of data on African American heart health in existence. So that's the major contribution to the Jackson Heart Study, and it will keep on contributing as time goes forward.
That's tremendous.
I may have gone on a little too long.
No. That's tremendous. That really is. That really is.
And let me hasten to say, it was not a single man's work at all. This was an army of people. We were funded by the NIH. I think by the time I left, we had possibly $250 million over the course of the study. It also involved educating young African Americans in research as well as stimulating a lot of them to go into medicine.
That's amazing. Martha, tell me about the, am I saying it right? The Women Take Heart study.
Yeah, so the Women Take Heart study actually was developed also for our criticisms of the Framingham, which was predominantly white, but also was predominantly male, their enrollees. So we actually set out to enroll just women, and we got 5,932 women to enroll in our
A
study.
little bit more.
And so we actually, what was amazing, we enrolled these women actually in a matter of 3 months.
Wow.
We
That's
provided
amazing.
daycare and valet service to make it easy for them. We put every woman onto a treadmill test. So this was in the 90s. And at that time, really all the information we knew about stress testing was based on male data, particularly from armies. Because before people could go to the army in the United States, they had to undergo what was called a Bruce protocol stress test. You run on a treadmill, we follow your heart every 3 minutes, it gets faster and steeper. But we only knew about how it applied to men. So we had the opportunity to put just under 6,000 women onto a treadmill and learn about them. And so that's what, so I actually can't even take credit that I started it because I was still maybe in university. But the PI actually, the principal investigator actually died, and I was looking for a project and nobody had touched it. And so I said, well, I guess that as a fellow, I was like, that's going to be my project. I'm reopening this study, and had the fortune of not knowing that they had not even entered data into the system. So not only did my job become reading 6,000 stress tests and getting paper cuts of reading those 6,000 stress tests, but I actually entered the data as part of my work by myself because there was no funding at that moment in time, but I really knew this data was important. So from that, we learned about what was a normal response for women. These were asymptomatic women, but across all ages. And we were able to develop things like what's the age predicted fitness level for your age? How fit should you be? We described that in our New England Journal article, but it was the first time because all the guidelines at that time just had men, like the male equation we were to use in women, and they didn't fit. Even the magic 220 minus your age that probably everyone knows and your smartwatch calculates for you. 220 minus your age, first of all, really doesn't work for anybody, but for women definitely doesn't, and we described that as well. We came up with our own less sexy formula. 206 minus 0.88 times your age is what women should be using. We published that in Circulation. We wrote to Apple telling them that they needed to incorporate that in for women. They didn't listen to us. But anyway, but we really didn't have that information. And so every day in cardiology, we do stress tests on people. And now the formulas that we use for women are the ones that are made in women, which is so important. And we've been following these women and using them as control to other studies, like the study I'm involved in called the WISE study, Women with Ischemic Syndrome Evaluation Study, where we've learned about non-obstructive coronary disease, which is much more common in women than in men. Even when you have a heart attack, women don't always have those tight blockages, but I've used my cohort as the quote-unquote normal controls. So we've learned a lot from these women, which has really advanced, I think, our way of understanding. Because without data, we didn't know anything. And I feel like when I started, all questions were on the table because nothing was really published about women.
Right.
These
these studies, when we talk about precision medicine, which is sort of a buzzword these days, it takes studies like Martha's and the Jackson Heart Study to be more precise, to help physicians know better how to deal with the person in front of them, and also to help people get their questions answered in a more precise way. So I think it's absolutely essential, critical work.
These studies are so important for that reason. They are also expensive. With our current administration, are you worried?
Well, okay, just a couple of facts. Morehouse School of Medicine was founded as an institution that is dedicated to health equity and justice. so that just that fact is important to consider. There have been cancellations of important work, either directly or as a result of sanctions against other institutions that we may have subcontracts with. So that's real. People will be laid off. Work will stop. Is it wise for us to be embarking on a path that will set back so much at a time when so many people are indeed vulnerable? How do we reconcile reducing access at a time when there are so many vulnerable people out there who will bear the brunt of the reductions? So I'll just give you a series of questions, and I'll leave it at that.
Okay.
Well, I think obviously it's going to affect the work that we've done. We've made so many gains in the short last decade, particularly related to women's cardiovascular health. And the concern I have now as we're writing grants, we're told that women don't need to be studied, and we're 51% of the population. So this isn't a special group, but it's a group that has been historically left out of research. And so now, when we're writing grants, we are told, don't write in the word woman. So now we're writing grants like this. We're saying, somebody with this disease, even if it's a female-specific disease, we can't say that anymore. Right. That's not going to get us points. We have to convince them in other ways. But it is concerning to me that these changes that are being taken, America, listen, I'm a Canadian. I came to the United States for a reason. I came here because the opportunities were rich here. You were able to study things that maybe other countries couldn't. Even a country like Canada, there was definitely more opportunities here. And now we're being restricted and we're going to go backwards, and America will not be the leader if they drop the ball at such a critical time, because it's going to take years to catch up again. You can't stop studies like the Jackson Heart study, if they ever did, and then not lose all that ground that you're trying to make. You can't stop studies that enroll women to study their hearts or their whatever organ that you're studying and then not lose that ground. We're trying to make health equitable. We've spent years trying to really put that as a message. How do we get this data? How do we fund the trials that are missing? So for me, I feel like we're going backwards, and I hope that we can work with this administration to help them understand that this work is critical for all of us. Somehow we're going to end up paying for not understanding people's health. As a preventive cardiologist, the earlier upstream we make sure we're making people healthier, we will spend less at the end of life. And right now, we spend so much at the end of life in the United States. So I think we got to work with this administration, and we need to be educating them really and get in front of them if we have those opportunities, and not fearing them, trying to figure out how we can work with them, because that's the only way to go forward.
Yeah, I couldn't agree more. And lest people think that studying African American health is somehow only helpful for African Americans. Many of you know the drug, if I can mention it by brand name because that's what comes to mind, the drug Repatha. Some of you may know. It is a marvelous drug for reducing cholesterol, and it's a godsend in many ways. So how did that come about? The Dallas Heart Study had maybe about half African Americans in the study, and this was conducted a few years ago. They noticed that there was a group of African Americans who, despite being relatively high risk, had extraordinarily good cardiovascular health. Extraordinarily good. They said, what's going on here? Fast forward, they find a specific loss of function, a specific mutation, genetic mutation, that basically neutralized a certain enzyme. PCKS9, okay, CCSK now. Okay. In those African Americans, this showed, there was suspicion about this particular gene already as being important in cholesterol metabolism, but this showed that you could safely have really low levels and that not be a risk for some other reason. So if you're a pharmaceutical company, you're saying, hey, I can come up with a drug and I can drop people's levels way down and not cause harm. That opened the gates to the development of this blockbuster drug that far and away more white people are using than black people right now, right? It's expensive too. My point is, if we start, working against this inclusion of, or this heterogeneity, let's call it, then we're working against ourselves. And so again, I ask the question, is it wise to begin to pull back in these areas? And I think we do need to have more and more dialogue with the administration about these areas and try to come to some understanding of what is truly good for the health of the country.
Truly good for the health of the country. That is a great place to end this part of the presentation. We have about 10 minutes left, and we'd love to take questions from any of you. Raise your hand. There's someone in the back there with a hat on.
Thank you. Hi, I'm Mary Woolley with Research America. Hi, Elizabeth. A big shout out to your panelists. I also have my long past history working on preventive cardiovascular prevention trials, the Mr. Fit project. Mr. Fit. That's all you need to know, right? We were doing what we thought was right at the time, but it wasn't, in fact, comprehensive the way it should have been. And fortunately, others have stepped up, like you, Martha. So here's it's not so much a question, but I'm trying to make it into one. In addition to having more dialogue with the administration, we believe that it's critical right now to be talking to senators all over the country who have the ability, as do members of the Congress, but the House, but senators especially, in order to stop some of the suggested cuts that are going on and reverse those that have happened already. I mean, let's face it, nobody ran for office on a platform of cutting heart disease research or cancer research, or the list goes on. And yet, that's what's happening right before our eyes. But it can be stopped. And I wonder whether you agree that we all collectively and individually should be acting in that regard, speaking out.
I think everybody has a role to be an advocate for what's going on. I mean, we can't make America healthy if we're not taking care of everyone, if we're cutting out the people that need health insurance the most, if we're removing what the gains we made with the Affordable Care Act, if that disappears, there will be many people left without insurance. So I think we're all, we spend a lot of our time too, not just being cardiologists, but also speaking to our senators and working with them and trying to tell them what the issues are. And we just need more of that from anyone who walks in those pathways, and you'd be amazed that you're always just a few degrees separated from your congressmen, congresswomen, senators. There's always someone who knows somebody, and if you can get time in front of them. I just found out that a colleague of mine knows RFK, so I said to him, I'm actually meeting with him on Thursday, to say, how can you get me in front of him? I just need 5 minutes to convince him that we need to do this good work. I believe we need to make the country healthy too. I would rather us not spend money on big interventions in cardiology. I know if we can do simple things like treat blood pressure, treat cholesterol, treat obesity, we can actually make less people have heart disease, and I could put some of my colleagues either into retirement or out of a job, and I'm okay with that. But we are never near that point. We'll never get near that point the way that we're approaching healthcare. So we all have to get there. And if you have any influence, please use it.
Yeah.
Sorry, I can't.
Right. Our,
Mary, can you, there we go.
I was just going to quickly say it. Our senator is also our pastor, Reverend Raphael Warnock, and he is someone who's very active in that area. I will say this too quickly. To be a female cardiologist, to be a black cardiologist, is not just being a cardiologist. You're going to have a lot of roles. You're going to be called on over and over to do things. And I charge those of you in the audience who are fit neither descriptor, you have an equally compelling obligation in this moment to let the people in power know what, again, is really important. They need to hear from you.
You said it well.
Okay, let's see. Any other questions? Lady in the green dress right here.
Hello, I am Jamila Stuckey, and I'm currently a Healthy Communities Fellow. I have a question, and I was thinking about some things specifically around African Americans in our community and women in communities and how we don't hear about or know about these studies. What would you say, one, is one barrier, and two, is one solution to that? And especially something I can take back. I'm from Tulsa, Oklahoma, so something I can take back to my community and share. Thank you.
Well, thanks for the question. I think you raise an important point. It is a failing of medicine to go and do all this work and then have it sit on the shelf of a medical library where it gathers dust. It's so important for us to move things from the bench, from the community research arena to people like yourselves, such that the word gets out. Quick example, I'm checking the time. When I first got to Jackson, there had been a recent publication that suggested that taking 3 servings of fiber a day would reduce the risk of heart attacks by 20% in a white population. That's what they call ERIC, a big study. And in black population, 25%. So when I first had my first community meeting before we got the study started, it says, so who's heard of this? No hands went up, right? Further, who knows what fiber is?
Yeah.
Third, who knows what a serving is, right? So the health literacy challenge for all of us is huge. And it begins with communications like this, but in many other venues, from churches and barbershops, all the way up to town hall meetings, which we made a big habit of in the Jackson Heart Study. So getting the community involved and letting them know, showing them the respect that, okay, we got this data from you, here it is again, here it is back, and this is how you can use it to do better. And what do you think? And then listen for what comes back from them.
And one thing that we did with the American College of Cardiology was actually creating information that people can use in community clinics. So something called CardioSmart. I was the editor-in-chief of that. But it wasn't for our cardiology colleagues. It was really for our patients and to be in centers. And this is all free. It's accessible online. They can send you posters. But it is communicating just that. Basically, we couldn't write anything above a grade 8 level, and were very graphic. These are infographics, and so it was a way to communicate salt, because when we say, how many milligrams of salt, it was the same question. What is that exactly? Is it, and describing it by a teaspoon or by number of shakes and things like that was a better way to communicate. But it does come down to this whole issue of poor health literacy. And I do think we need to start thinking of big ideas, of strategies, of providing basic health literacy to kids. You start them young and you start teaching them. And we do have some data from Valentine Fuster's work where they started with 5-year-olds. 5-year-olds were going home telling their parents about the number of fruit and vegetable servings they needed and changing the family, not just changing them. So we can't think that it's not possible, but we do need to think about how do we make that part of your education. If people left with a better health literacy, they would be healthier, and that's good for all of society to thrive.
Well, this has been amazing, and I'm so sorry we are out of time because I know that we could continue this conversation for hours. But thank you all so much for coming. Really appreciate it.